Growing up in an area with few Asians, my parents had difficulty integrating into British society as first-time migrants with not a lot of money. As my parents struggled to integrate, to some extent, I asked myself, where do I fit in? Who am I trying to please? This is my story about being faced with challenges, being diagnosed with schizophrenia and also with a personality disorder. They have been very life-limiting. I've lost the ability to live, to function, and to be part of society. School wasn't very positive about different cultures. Teachers were always making everything into a big drama, like talk in English, don't speak in your language. I'd say to the teacher, Miss, we eat with our hands. And they were like, well, we have forks, why don't you use a fork? School was also traumatic because I was heavily bullied as early as primary school. I felt excluded as I was constantly anxious and worried about my safety. I always thought, am I going to be safe here? Secondary school was very segregated. But I thought to myself, through an education I could succeed and pursue further in life where I wanted to go. But at university, I experienced a lot of racism from other students who would never talk to you because they had such negative opinions about ethnic minority people. How can someone from a BME community be able to, go to a good university and have a good education? My white roommates didn't understand or want to understand anything about my culture, my traditions, what religion I've been brought up with, and how important these are. But I transferred to another university. And it was like going from a negative to a positive. This college even had Diwali. We did a drama about an Asian wedding. I felt very proud. My skills, my talent, my experience, my culture was being appreciated. That's when I started to feel positive about my religion and culture. I still find people from BME communities are a target in Britain. We're seen as criminals. There have been multiple incidents when I've been questioned by the police, which I think is racial profiling. Just a few weeks ago, I was questioned by the police when I was in the city centre roaming around. You like to think the police are there to support you, to offer assistance and guidance. Like incidents when I've been threatened by people where I've lived. And on top of that, with a mental illness and a close-knit South Asian community, there's a lot of shame because of a taboo or a cultural lack of understanding around the illness. You're trying to deal with that on a daily basis in the community, trying to explain, I'm not mad. I graduated with a 2-1. My parents came to my graduation ceremony. I felt very pleased. But the following August, I had difficulty sleeping and began hearing voices. I was experiencing a lot of stress, anxiety and worry about the future. I began feeling very disengaged from people. The voices became increasingly distressing. They were overpowering, loud and demanding, telling me, you must do this, you must get angry with people. By the winter, I was sectioned under the Mental Health Act. It was very traumatic. Like I could barely understand what had happened. And I remember the consultant and the psychiatrist coming into my room, asking me some questions, and being observed by the Mental Health Capacity Act assessor. All I remember is being heavily injected, and then some nurse going, "We'll see you in a couple of weeks." And then 6, 7 months later, hearing I was ready to go. But I lost my willpower, my confidence, my motivation, my ability to live. Decisions were being made on my behalf. It just felt like, where should I go? I'm dying. It felt like I can't help myself. I want to help myself, but how am I going to be able to help myself? Even today, the way the mental health system treated me, I feel like it's appalling. It's just a very traumatic experience. Whenever I've spoken to my GP, they only talk about medication. They don't talk about any alternatives such as therapy. They said, "You've had therapy and that's it." Then they stop the conversation. So I remain on medication, even though I do feel the medication has caused me a lot of damage. I would constantly be sleeping 12 to 24 hours. I would only wake 1 hour a day. And when I question my psychiatrist or GP, my experiences or concerns get ignored or diminished. I realise I need help. What I don't understand when I question the professionals is why the need for me to be on such high dosages. I've complained heavily to the NHS, but I always get the same response. Why are you creating a problem when there is no problem? But my concerns haven't been represented. I've been listened to, but no action has been taken. It's the system and the medication that's made me ill and hasn't enabled me to speak my voice. Where is our voice? I want to be heard.
Where is our voice? I want to be heard. Very powerful words that gives us some insight into challenges that some populations face. We have a panel that will hopefully shed some light on what we may be able to do about this. The next topic we will be dealing with is what works in reducing inequality in healthcare. And before the panel comes up, we have a plenary presentation by Professor James Nazroo. Professor James Nazroo is a member of the RHO board. He's a member of the International Advisory Group, and he is a professor of sociology at the University of Manchester. And when I talk about James to other colleagues, I say he is the leading expert on race and health in the United Kingdom. Professor Nazroo.
Well, I appreciated that. I must say, lightened the mood after Fazli's very upsetting story. I'm actually not going to talk for very long, so it's not going to be a long plenary. I'm going to try and talk just for 5 minutes or so, and then we're going to have a conversation. Each of the members of the panel are going to talk for 3 to 5 minutes, and then we're going to open it up to the floor. But we're also going to present you with a challenge in terms of the what works question, and that challenge will also go to the online attendees. I want to start by saying this conference is absolutely amazing. The amount I have learnt listening to the speakers, to the conversations, but also, and again, apologies to those online, but also the conversations we've had outside, social as well as intellectual, around what's going on in terms of race and health. I am unapologetically going to repeat things that other people have said today. And that's in part because it's so important, but in part because I'm not very imaginative, so I'm going to say the same stuff as everybody else as well. But there you go. As I say, I'm not going to talk for long. My starting point, of course, is the starting point of this meeting. That ethnic, race inequalities in health are deeply, deeply embedded in societies of the global north. Not only are they deeply embedded, but they are unchanging. And they are unchanging over the 30-odd years that I've been doing research in this field, but unchanging before that as well. They are unchanging. And I'm not just talking about inequalities in health, I'm talking about inequalities in economic position, inequalities in social location, inequalities in how we are valued, and so on, and inequalities in how we are placed in terms of politics and importance. Deeply embedded, unchanging. In that context, you perhaps will be surprised, maybe not be surprised to hear me say that we have seen little or no meaningful investment in systemic policies to change these inequalities. So you may disagree. We've heard speakers talk about the things that are going on. My argument would be that these are still around the edges. They're not challenging the systemic issues that we face in terms of these inequalities. I fully accept the point that Andy made yesterday, that the small change leads to another small change, leads to another small change. But this is where we are. Small changes happening piecemeal in various places, and we need to think more deeply and more profoundly around what's going on. So my argument is that, in part, the lack of policy in this area reflects a resistance to accepting that ethnic race inequalities are important and that racism is important. So within this room, within the online space, we all care about this. But we are a minority, in my view. The way in which people approach this problem is really quite different to the ways in which we approach this problem. And they refuse to acknowledge that the problem exists. So part of our role is to make that very, very clear. I also argue that even for those who are determined to address these inequalities, there is an uncertainty about what to do about them. So the lack of policy in this field is also in part because policy analysts, those responsible for policy, do not have the critical tools to understand what is driving these inequalities in health. They can't adequately frame and interpret the question and the analysis that results from this. They perceive this to be exotic, unfamiliar territory. So policy leaders approach the topic using lay concepts and science rooted in colonial thinking. So just turn to Fazli's story briefly. I will turn to it again later. How many of you kind of connected with the notion of a community that was shamed by mental illness, the stigma in the South Asian community attached to mental illness? You know, this is a common narrative. The problem that we face in the provision of mental health services is because there's so much stigma out there, and particularly amongst ethnic minority communities, they don't come to us. But actually there's stigma in white communities as well. How different is the stigma that's present, that Fazli experienced? How different is that stigma from the stigma faced by white people with severe mental illnesses? And then actually where we think about the origins of this stigma, why do we fear mental illness? Is it because of the experiences of people with mental illness? Is it because of the ways in which the diagnostic categories are constructed, used, mobilized by clinicians, by professionals? Is it because of the experiences that people have in care? I think we need to think very critically about the common sense understanding of the kind of narratives that Fazli offered there. They become embodied in the ways in which we talk about ourselves. but we need to think critically about what's being said, and carefully. So, I think, as other people have said, a starting point here, a starting point to achieving change is to recognize the problem. That race, ethnic inequalities in health are vitally important in our societies. And that they're not driven by exotic genes, they're not driven by strange cultures, they're driven by racism. Racism is the fundamental cause of these inequalities. As Michael Marmot said yesterday, we need to step beyond the surface and look at the fundamental drivers. But simply acknowledging the presence and importance of racism does not provide us with the tools to address these inequalities. Racism is often seen as an impossible target rather than as a call to action. So we see our leaders talk about systemic racism, talk about the need to acknowledge it, talk about the need to develop strategies, tactics, but we don't actually see them do anything because it's an impossible target. They do not understand what they need to do to address the issues of racism. My argument is that if we understand the ways in which racism operates, then we begin to obtain the tools to address it. So we have to think carefully and critically about how racism shapes our lives. And there are many ways we can do this, and we've heard quite a few attempts to describe how racism some real accounts of how to describe racism and how it operates in our lives. I'm going to offer you another way of thinking about it. It relates very strongly to what's been said before, but another way of thinking about it is really intended to be entirely pragmatic, to try and identify the steps that we can take. So I talk about three interrelated types of racism: structural, interpersonal, and institutional. This is just a tool. They're deeply embedded in each other. It's very hard to distinguish them in real practice, but it is a tool that allows us to get leverage to achieve change. So structural racism results in inequalities across a full range of resources, not just economic, not just social, but also cultural, political, and physical, and so on. A whole range of resources that structural racism provides inequalities in accessing them. And we've seen the depth of those inequalities in various talks from around the world. Interpersonal racism, we can see ranging from discrimination to mild, ignoring insults, everyday incidents, to actual physical aggression, violence, and verbal abuse. These are all forms of violence that undermine our position in society, reveal our insecurity within society, the insecurity of our position in society. And not just those people who are directly targeted and directly experience it, though most of us do, but also those who have similar identities. You know you're not valued, you're not safe in society. These conditions of social and economic disadvantage, as we've heard, and the experiences of racism impact on our biology, impact on our health, cause illness directly. A huge amount of evidence demonstrating that, and also demonstrating that the ethnic inequalities in health that we observe are being driven by these factors. But institutional racism is crucial. So structural racism and interpersonal racism also shape our encounters with institutions. Institutions that provide key services to us. So we can go from health to social care, to employment, to education, to criminal justice, to politics, and so on. They shape our access to resources, and as a consequence, they amplify the inequalities that we experience. We kind of had that illustrated a little bit in Fazli's stories. He spoke of his journey through various institutions. There were moments of hope there, of course. The second university that he went to was an affirming place. Institutions don't have to do this. We need to think about the role of institutions in our society and how they can be transformed. But my argument is that because of their central role in both providing us access to key resources, but also in terms of potentially mitigating the harms that we experience, institutions are the place for action. So this means addressing institutional racism, carefully examining the role of the institutions that we are within and that we make use of, and how they variously and jointly shape inequalities. So addressing institutions and addressing institutional racism, my argument also is that public institutions, at least in the UK context, are crucial here. Public institutions are places where we can lever change. So they can develop policies that address racism and the marginalisation of ethnic minority people within their services and within their workforces, and ensure that they provide equitable outcomes for their services and for services that they commission from others. And in doing so, they shift the ideological framing of inequalities from a problem of them to one of us and the need for us to change inequality. Of course, public sector institutions describe themselves as anchor institutions, and it would be good to see them use their role as anchor institutions to change the nature of the societies within which they operate. So you can think about this in terms of the staff they employ. Huge number of staff employed in the public sector. Changing the employment conditions of staff. Ethnic minority people are overrepresented within the workforces of the public sector. If you change the conditions of employment for staff, then you change the conditions of employment for public sector workers, for ethnic minority workers. But not only that, other employers have to compete. We heard Amanda Pritchard talk about the NHS aspiring to be the number one employer. If they're the number one employer and other people want to compete with them, then they have to do the same as the NHS in terms of attracting a workforce. In the Manchester context, we have the NHS, we have the local council, we have the university, and we have the airport. If those four institutions changed what they did, the employment conditions in Manchester would transform dramatically. But they would also have to change what they do in terms of the ethnic minority members of their workforce, where they're located within the structure of their workforce, how they're celebrated, how they're promoted, how they're protected, and where leadership comes from, and thinking about ethnic minority leadership. More fundamentally, I argue that institutions need to rethink and reshape their structures and functions, the services they deliver, and the purpose for which they deliver those services. When Heather was talking, it really struck me the ways in which certain of our institutions play a crucial role in regulating black bodies. And we can think about this in terms of criminal justice, she gave the example. We can think about this in terms of mental health systems, but also in terms of education, in terms of social work, and so on. How far do we see our institutions as being rooted in colonial thinking, their functions embedded in colonial thinking, and being translated into the modern day, continuing to do the same things? Why is criminal justice about locking people up and locking black people up? And we could ask the same questions about school exclusion and about mental health services. So my argument is, and other people have touched on this as well, that we need to adopt a decolonisation agenda within our institutions, and to do so seriously. So what does this mean? This means thinking about the colonial history of our institutions and how that translates into contemporary functions. It means thinking about who is valued and who is not valued in the services that we provide, the people we employ. It means thinking about what forms of knowledge are important. And so Janet's comments on that, Irma's comments on that were crucially important in terms of colonial history and indigenous populations. Whose knowledge is valued? Whose experience is valued? And how outcomes are prioritised. So again, if we think about criminal justice, schools, social work, and mental health, which are the outcomes that are prioritised here? That FASLI is controlled in certain ways to not be trouble, or that FASLI's well-being is looked after. And we also need to think about the history of our institutions, and I think that particularly in terms of universities, which is where I'm located, but also other institutions. The histories of our institutions, how they came to be, and how that relates to their functions, which elements of that history we celebrate, which we acknowledge and which we deny. Of course, this is fundamentally challenging of the focus and actions of institutions. It requires the leaders of institutions to rethink the services they provide and how they are provided, and how the services they provide lead to and amplify racial injustice. So we can hear Amanda beginning to move in that direction. We need to encourage our leaders, and a brave example, but we need to encourage our leaders to continue to move in those directions, but to do so in fundamental ways. It needs strong leadership, but also fundamental reform, not just tinkering around the edges. And maybe the move is change small things at a time, but behind that is an agenda of fundamental reform. But the other thing I want to say, and I want to close on, and Brian has repeatedly, in one way or another, encouraged me to do this, is to talk about who leads this. Who gives up power? Who takes up power? And who leads this? And so this needs to be led by the people who use the services and the people who work in these institutions, not by those who currently have power. And again, I think Victor said something about professional resistance. We do need to think, those of us who are members of professional bodies, we do need to think what our professions are doing in terms of maintaining our power, our authority, and our decision-making, and the importance of giving that up. Okay, I know I've spoken for too long now, much longer than I said I would, but thank you very much. So maybe the panel members can come up and we can relax and open up a conversation. Okay. So, yep. So we have some repeat offenders on the panel, as you can see, coming back to my notion of controlling bodies. But I'll briefly introduce the panel members, and then I'm not going to pose questions. I'm going to ask them each to reflect from their own space in terms of what works, what we can do. So, Laurie Zephyrin, who is, I'm going to have to read it even though I've heard it several times, Senior Vice President, Advancing Health Equity, the Commonwealth Fund, and is a member of our International Advisory Board. Bola Owolabi, who is Director of Health Inequalities at NHS England and NHS Improvement, and has been a crucial ally in the work that the RHO has been doing. Derek Feeley, who is now Senior Fellow at the Institute for Healthcare Improvement, formerly the CEO, and has also been a vital voice in this space. And of course, Dr. Habib Naqvi, who is Director of the RHO. I think we could just take it in turns to reflect on what's happening in your space in terms of what works. Yeah.
Sure. Thank you, and thanks for that overview. Really powerful article that was just published where you defined the different types of racism, from institutional to structural to interpersonal. I think to your question, as I think about what works and possibilities, I think it's really important to seek to build and rebuild trust of the communities that we serve. And it's really more than saying like they have to trust us, right? Because in the as a clinician, in the patient-clinician interaction, for example, there's already a power dynamic that's built in. And so when you're talking about health systems, there's already a power dynamic that's already built in. The healthcare system is big, it's powerful, and has ingrained structures, as you talked about, and processes that promote inequities that have built-in biases. So when we think about trust, I always say, we won't tell people to, run into a burning building, trust us. We have to really understand that consistently providing poor outcomes, poor experience, and poor treatment doesn't build trust. and it's up to the systems to really engender that trust and to create that trust. And so I also think about, in terms of, as we think about healthcare systems building that trust, having the data to be able, and making that publicly available is important to be able to engender that. We talked about maternal health yesterday and addressing maternal morbidity and mortality and achieving equity there. We do know that in terms of what works, a lot of it involves community engagement, and really letting the communities lead. When we talk about midwifery-based care models, when we talk about Black-led centering pregnancy models, when we talk about Black-led birthing centers, what we're talking about is redistributing the power to the communities to allow communities to lead and care for people in a way that centers people. When we talk about doulas and community health workers, the healthcare models that integrate that really centers community. So that first part, I think, is just is really engendering that trust with community and leading, having communities lead and sharing that power from a financial perspective, as well as from a centering perspective. I think the other piece is around being accountable to our pledges to foster equity. I mean, with COVID-19 and the racial reckoning, a lot of health systems really made a lot of pledges around advancing equity, commitment to racism, and so it's really important to hold ourselves, hold health systems, policymakers accountable to those pledges in a meaningful way. And I think one way is to, I think about it, and we think about it as Commonwealth Fund, how do we help drive policy change to create incentives to uphold those pledges, and disincentives to not uphold those pledges. And I think payments can be very powerful to create incentives for health systems and health leaders and accountability. And one example that I'd like to just highlight in terms of work that we funded, and Dr. Holmes mentioned it a little yesterday in his talk, we've funded RUSH. They've really they've put together a racial equity progress report in concert with the community that not only addresses their people, like sort of the diversity of leadership, the staff that they hire, they sort of focus on wealth building, to also focus on patient outcomes and really providing that data and making it accessible to their strategy and integrating equity into their strategy and integrating community as well. And they've partnered with the Illinois Health Association to roll out this racial equity scorecard to all the healthcare systems in Illinois, right? And so that's to create accountability for advancing equity across all domains, not just within the health system, but beyond. And I think models like that are very useful to partner with communities and really think about whole health and advancing health equity.
That's great. So move on. Yeah, Bola.
Thank you, Laurie, and thank you, James. I think it's been an excellent conference. Congratulations to the organizers. I think my reflections will be based on the experiences during the COVID pandemic, particularly an element of the pandemic response, i.e. the vaccination rollout. And my reflections could be summarized into how do we elevate the conversation from analysis into action and from policy into practice, and to elevate from a moral and ethical imperative into a more engaging space for those for whom this is not a natural space to occupy. What do I mean by that last comment? I point you to the Harvard Business Review and their series on the diversity of boards, making a really powerful case for the greater productivity, profitability, and efficiency of organizations with diverse boards, so that those who will not come into the conversation on a moral and ethical basis can at least find other levers and reasons to join the conversation. I think that's incredibly important. So what did we learn from the COVID vaccination deployment that will service the point of analysis into action? We disaggregated the data. I think back in January 2021, when we looked at the vaccination uptake rates for those over 80, our first cohort, we were rightly proud that the uptake rate was 82%, which by all standards, even then, was world leading. But what disaggregation did was help us to see that the uptake for Black Africans was 38%, Pakistanis 44%, and people from the most deprived communities 45%. A distant cry from 82% headline. But more importantly, what that disaggregation did, it gave us actionable insight. It gave us actionable insight that began to drive some real interventions, like the vaccine taxes, like the vaccine buses, like putting the vaccine in places of worship. And we watched the numbers move. And I think it's really important to hold these learning in mind as we move into the what works space. I talk about creating virtuous circles of data, whereby data leads to actionable insight. That insight drives tangible interventions, from which hopefully we derive some improvement and gain intelligence about what works. And let's go around the loop again. Secondly, what did we learn? The power of an appreciative inquiry approach. So rather than looking at the communities that were behind the curve in terms of vaccination uptake and talking about them as the problem communities, we looked at those communities and asked ourselves, what is it about them that we could tap into and build on? And we discovered that these are communities for whom faith is a fundamental part of their sense of self, not universally, but significantly. We also discovered that these were populations for whom the sense of community was a fundamental part of their identity. So we tapped into those two things. I and many others got on the phone to the imams and the pastors and community leaders. We brought them into the conversation, and they told us what to do. They told us that putting the vaccines in the Gulf Coast was a bit of a non-starter because our people don't go there. Thank you very much. But this was the power of appreciative inquiry. And it's really important that we find a way to begin to craft a narrative that moves us from the deficit space into an appreciative strengths-based space. What else did we learn? And it's been repeated often over the last couple of days, the power of co-production. Talking to the communities helped us to see the blind spots. They helped us to understand that simply translating messages into 50 languages doesn't translate into culturally competent communication. That it's a far more nuanced issue than language translation. We learned that the messenger is just as important as the message. We began to mobilize trusted voices and faces, and we saw the numbers move. And finally, what did we learn? Leadership and accountability. We had named senior responsible officers right across the country between health and social care to ensure that there was equitable access to the vaccines. And we used the data to monitor our progress. And we asked questions when the numbers did not move in the direction that we all wanted. And so if we use the COVID vaccination and the pandemic response more broadly as our frame of reference, I think those 4 things will serve us well as a way of moving from analysis into action. Thank you.
Thank you, Bola. I echo your thanks also to RHO for organising this event. I've learned a huge amount today. The thing that really touched me when I first saw Fazli's video was when he says, it's the system. And it reminded me of something that we say in the world of quality improvement, which is every system is perfectly designed to get the results it gets. There's nothing accidental about Fazli's experience. The system is designed that way. And so if we want different results, we need a different system. Sometimes that can feel quite daunting, this idea that we need a different system. It's maybe one of the reasons why what we see is exactly as you said, James, lots of small changes that never become systematic. And I won't pretend that I know for sure what works. However, over the last 5 years or so, IHI has been working in collaboration with a number of healthcare organizations in the United States. But I think there's transferable learning to better understand what might work. And we're finding 5 things that seem to make a difference. Firstly, the healthcare organization needs to make health equity a strategic priority. It was the price for entry in the first wave of pursuing equity, and you know we could hardly find a healthcare organization that had an explicit commitment to health equity in their statement of strategic intent. That's changing, but you need to do that. We need to start talking about equity with the same commitment and passion that we talk about patient safety. And I love it when leaders like Amanda talk about quality and safety, as she did again this morning, but I would love just to add and equity. So every time we said we're going to work on quality and safety, we just say and equity until it becomes just what we say, quality, safety and equity. So making health equity a strategic priority. Second, the successful organizations have been able to build some kind of infrastructure to support health equity. So some of that is the data that people have talked so compellingly about during the course of this conference. Some of it's in those hiring practices, James, that you talked about. The University of Arkansas Medical Center has raised salaries for all of their staff to in excess of the local living wage, and of course that has a disproportionate effect on their staff of colour. So building some kind of infrastructure. I also work with NHS ELFT, and one of the things we've done there just at recent board meetings is we take a particular subject, last time it was access, and we do an equity deep dive into that, and there's huge learning, even the extent to which we have to disaggregate to get useful information. So it's not enough to talk about Asian, for example. Huge differences in the way in which subcultures access services. Third thing we're learning is that where organizations address both healthcare inequity and the social determinants of health together, they can move a little bit more quickly. So that's where I think anchor institutions and the stuff that Michael Marmot is trying to promote has great promise. If we can connect our NHS organisations to those initiatives, I think we might get some kind of springboard effect. The fourth is, though the organisations seem to be able to make progress if they partner with communities. No surprise perhaps, but definitely still worth saying. I think some of the missteps that healthcare organisations have made in the past is they think they know all the answers. And I think in this space in particular, the job of the leader is not to have all the answers. Not to have all the right answers, but rather to have all of the right questions. And the fifth is that we're finding organisations need to walk their talk. They need to eliminate racism and other forms of oppression inside their organisations in order to be credible outside their organisations. Again, no surprise there, but worth saying. So I think the good thing about that, James, is there's not a single healthcare organisation that I can think of in the United Kingdom that couldn't do all 5 of those things tomorrow. And okay, maybe it's not changing the system, but it's starting to change the system.
So the challenge of going last. The challenge of going last is that I'll be repeating what's, but in a way that's reassuring, because we do know what we need to do. The trick, as colleagues have said, is turning that rhetoric into action. And the 3 points I had down were firstly the data, which is a common theme throughout the 2 days around what we need to do, but not just outlining the scale of the challenge, but also turning that data into insight so that we get actual action that makes a positive difference and produces solutions. And that includes, of course, engagement with our communities, patients, and our workforce. But engagement that's not piecemeal, but it's sustained and it's meaningful over time. And that's easy for me to say, but to actually do that is absolutely critical. The second is accountability, making sure that this is everyone's business, making sure that this is within the annual appraisals of everyone that works in the institution, so that they're asked after 12 months in their annual review, what have you done around equity? And what's the evidence base? What's the outcome? What's the positive outcome as a result of that? But of course, we want people to do this because they want to, and not because they have to as a result of contract or assurance or regulation. And so making sure that people's moral compass is pointing in the right direction is absolutely critical. Going back to Bola's point, which is absolutely right, making sure that the narrative is right so that people can buy into what we're doing and really understand why we're doing that is critical as well. And with that accountability, one of the advantages of the observatory is that it's independent. So it's holding up a mirror to the rest of the system in a way that enables people and organizations to have confidence in the data and the evidence that we produce, have confidence in the recommendations that we put forward, and in the support that we will go forward and provide as well. And that leads to the final point, the third point, which is around leadership. And it goes back to Victor's point at the beginning of yesterday, which is about making sure that this is everyone's business, making sure that the moral compass for everyone is pointing in the right direction, making sure that we not just acknowledge the problem, but do something about it, and making sure that everyone has that responsibility. Trust, rebuilding trust is part of that leadership thing that we need to do, particularly as we come through the pandemic. And then the final phrase, again, stealing this from Victor's speech, excuse removers. This needs to be an excuse remover. We need to make sure that we need to do that. And that's easy for us to do, I guess, from the observatory's perspective, from an independent perspective. But if we can create the cultures for everyone to do that within their own organizations, I think we'll be heading in the right direction.
Thank you very much, everybody. Yeah, I think a round of applause for your contributions. I'm not going to, I was beginning to sum up some points here, but I'm not going to try and do that. There are enough connections between what's been said by our four panelists here. I would really strongly encourage you to get this clip of their four contributions and listen to it again. and begin to think through what that means for your personal action. Which takes me to a question that Derek, we've put Derek up to ask a question of the audience, including the virtual audience, which we would like you to respond to.
Yeah. So this is a mechanism we use in quality improvement to people to act. And so our question is, what do you pledge to do differently by next Tuesday? As a result of what you've heard over the course of the last 2 days, what do you pledge to do? I'll start again. Is it? I hope it's the mic and not my accent. Which, having spent 7 years in America, you can tell I've got this Boston accent now. So the question again is, what do you pledge to do differently by next Tuesday? On the basis of what you've heard over the last couple of days, what do you pledge to do differently by next Tuesday? And we'd love to hear that from you, because in collecting your input on Slido, we'll be able to do some sense making and get some kind of idea about the activity that the conference has generated. For me, it's learning more about cultural safety. That's the thing that I'm going to do by Tuesday. I hope everybody can commit to doing something.
So, James, shall I stay with the other microphone? Yeah. So follow the link, and while we're having questions and answers, provide your responses and continue to provide them afterwards. And as Derek said, I'm going to commit the RHO team to look at the responses that you've given, and we will try and make sense of them. So please do this. But now is a time for questions. So we do have, I think, at least 5 minutes, maybe a little bit longer, for questions. Both virtual, both from the virtual audience and from those here. Yeah, you have to do Slido and ask questions at the same time. Yeah, it's coming up.
Thank you, James. I'm Bren. I just volunteer in local community and a member of the Race and Health Observatory stakeholder engagement group, really, and proud to do both. Very proud, really. So my question really is about actually building up trust again within our communities. And I think it's going to be one of the key measures of just about most of the things we do, if not all the things that we do around trust. What sort of measures are we looking through the eyes of the community? Not the measures that we're going to give the community to say that, but what are you thinking in terms of, again, listening to the community so they build their measures up in which they ask and actually get responses and also hold to account? So basically bottom up from trust and measures.
So I'm going to hand that to Laurie first, because she was the one on the panel who raised it first, I think. Yeah.
Sure. You know, that's an excellent question. Thank you. You know, a couple of things. One thing that we've been focusing on is to build trust, particularly as we think about maternal health care. In the U.S., there's a lot of funding, federal funding going out to try to advance maternal health equity, right? And the challenge is sometimes that funding doesn't get to the people doing the work. And so part of what we've been doing is we've funded some partners to engage with community-based organizations that are leading this work that don't have the capacity necessarily to apply for grants because they're doing the work, and really providing that technical assistance, right? So I think one way to build trust is to ensure that the resources go to the communities that are doing the work. That's really important. Another thing is where there's also a number of policies around equity and maternal health equity that are just moving forward in the U.S. context. And we haven't really talked to mothers, birthing people about what they think about those policies, particularly around postpartum Medicaid extension as an example. And so we actually have some qualitative work actually talking to people in the field, to birthing people, to mothers, about what does this policy mean to you? What would you want it to look like? How do you want us to engage? And so that's also work that we're doing in terms of talking and engaging with community as well. Those are some examples, and I'm sure there are others I can talk to as well, but I'll give room for my other panelists to comment.
Thank you, Laurie. One of the phrases that I've found incredibly helpful over the years is measuring what matters. And I think you only know what matters when you ask the people who are the subject of the discourse. So as we go forward into our integrated care systems, as we build our system accountability frameworks, I think it's incredibly important that we ask the communities that we serve what matters to you, and build our measurements on the response that we get back from that. And that way, I think we begin to make inroads in building trust again.
Do the other panelists want to?
Only to say I think it's important that we don't separate the measurement from the work. And measures should flow from the work that we do together. And if we do the right work together, we'll find the right measures. I find it's particularly challenging, I think, because if you start with measurement, you sometimes find it very difficult to actually get to the work because you can never agree on what the right measures are. So my advice would be, let's start with figuring out together what work are we going to do together, and then the measures will flow from that.
And I just add, as we heard from Roxy earlier on today, how crucial it is in the academics field as well, to be thinking about what the people we are working with in terms of research would like us to study and how to study it and what kind of questions we should ask. That was an aside. Let's have another question. We do have a couple more minutes if there's another question. Yeah. And do we have any online questions or no?
Thank you. Brilliant session, brilliant conference. Just a question about the Messenger review, because it said equality, diversity and inclusion needs to be the responsibility of everybody and every leader. Yes. It also said there shouldn't be, or very soon shouldn't be, dedicated equality, diversity and inclusion officers. And I'm just really interested in whether or not you agree.
I believe you need both. I think Messenger is right that it should be the responsibility of every leader, but until it is, I think we definitely need dedicated resources of that kind. And I would hazard a guess that even once that is achieved, that nirvana, we'll still need it, because the field of knowledge will move on, and therefore we need some expertise to keep those leaders up to speed. So I think we need both.
I think Laurie wants to.
Yeah. And just to add to that, I agree. I totally think we need both. There in the U.S., there's a number of roles that have opened up within health systems around chief health equity officers and health plans, et cetera. And we're doing some work to just better understand what they're doing and what resources they need. But what I've seen, there's just a number of variation. In some health systems, the chief health equity officer reports to the CEO and is on the C-suite and is responsible and incorporated in developing the strategy that goes across the healthcare system. And they have access to resources and data and built into quality and safety. Whereas in other health systems, they're sort of siloed off as their own team. And so part of what we're trying to do is, and other organizations, IHI, the American Medical Association, are really looking to how do you create a playbook for health equity officers and CEOs to really center health equity as part of the organization. And you can have a chief health equity officer that's helping carry out that strategic vision and lead that strategic vision, but it's incorporated into the strategy of the entire organization. So I agree, it's a both and.
And Bola.
I'm mindful that we are out of time, but I think it's important to distinguish the functions of the dedicated roles versus it being everybody's business. I think those dedicated roles enable us to gain focus so that we can achieve some traction, and with that then comes the impact. But the more dispersed roles enable us to hardwire, and we need to do both. There's something about hardwiring it into the body politic of the organization, and therefore you need the social movement. You need it to be everybody's business. But the focus, traction, impact still needs to reside within the dedicated resource space as well.
Thank you. I think we need to close our session now. So thank you, everybody. Thanks to the panel.